this topic, sudden death in the cardiac center. Is it a myth or a reality? We'll be having this outline, and our objectives have been to determine the presence of early cardiac death and to demonstrate the associated comorbidities of cardiovascular death in the cardiac center. We all know that sudden death occurs majority of the times at home or out of hospital. So we don't have any conflict of interest to declare. And following the document of the World Health Organization, definition of cardiac death, sudden cardiac death is non-violent, unexpected death within 24 hours of onset of symptoms. Most of the time, the primary etiology has been cardiovascular causes, accounting for 70 to 90% of cases. And globally, 32% of global deaths have been accused to be sudden cardiac deaths. In Cameroon, there was a recent study in 2017 that proved that the rate of sudden cardiac death was high at 33.6% per 100,000 persons. And that 63 of these deaths occurred out of hospital, 55.5 of whom were at home. We considered our series starting from January 2024 to December 31st, 2025, a period of 2 years. Was a retrospective descriptive study. We got this authorization from the Ethical Committee of the St. Elizabeth Catholic General Hospital Cardiac Center. We considered evaluating 1,774 files, where we found out 150 deaths of all types. We retained 16, the ones that we analyzed. These 16 files, we considered some particular parameters: clinical presentation of the cases, the duration and hospital contact, probable diagnosis before death, and comorbidities that were identified. Our results proved that majority of those cases were male, and majority of them again were above 60 years of age, with a minimum age of 25 years and a maximum of 89 years. This proved that advanced age has something to do with the event, which was cardiac death, to our understanding. We also evaluated and found out that there were a series of symptoms, and the most presented were neurological symptoms. We're moving from non-responsiveness, unconsciousness, sudden vomiting, left side weakness, dizziness, severe headaches, incoherence, collapsing, and also slurred speech, amongst others. Breathlessness was equally associated and very much present. The duration of hospital contact for the 16 cases, we evaluated and discovered that 3 of those cases died on contact immediately as they entered the hospital in 0 or no arm. That was 80.7% of those cases. The majority of them passed on before 9 hours of admission. Now, for the 3 that passed on, we wanted to make this note. We have an 85-year-old male with controlled blood pressure values, no comorbidity, presenting with sudden onset of headache and left side weakness. They were lucky to be carrying the patient to the hospital within the same hour of presentation. A proper diagnosis of cerebrovascular accident was made, and that case equally passed on. The second was 66-year-old female with a very small blood pressure of 80 on 47 millimeters of mercury, who presented with sudden collapse and breathlessness with a comorbidity of hypertension. The most probable diagnosis here was cerebrovascular accident and acute pulmonary edema. And the last case was an 80-year female with blood pressure of 93 on 56 millimeters of mercury, presenting with sudden unresponsiveness, having as a comorbidity hypertension, and still cerebrovascular accident was accused. The comorbidities that were present and identified in this series was hypertension, kidney disease, and diabetes. Majority of the cases, in 68.75% of cases, were having hypertension. This was pointing to the fact that most probable hypertension in the elderly was a bad announcement. 31% of these cases were not linked to any comorbidity. And the most probable diagnosis that we retained here for many of the participants or the patients was cerebrovascular accident in 6 isolated cases, one associated with acute pulmonary edema and another one associated with malignant hypertension. Equally, there were still some other diagnoses like acute pulmonary edema isolated that was present. We equally evaluated the blood pressures of those patients. The maximum was 217 systolic and the diastolic was 132 millimeters of mercury. This was in a patient that had an association with kidney disease. We were then reflecting that most of the cases were elderly, predicting that the advanced age is actually bringing along with a lot of vulnerability and presentation of the event. The most represented symptoms were still pointing to the fact that the presence of hypertension predisposes most of these patients to a cerebrovascular accident that actually carried them away very soon. The frequent comorbidity was hypertension. This was actually a cause for concern because many of those people whom we evaluated among the 1,774 files, they were all having hypertension. We noted that majority of the blood pressures were not, the majority of the cases had hypertension and died prematurely with a probable cerebrovascular accident, pointing to the fact that there is a probability of this cardiac death that occurred that is not linked to blood pressure values, but it is actually linked to long-standing history of hypertension. And we are concluding by saying that, yeah, the cardiac center has detected some early cardiac deaths, and our results were pointing to the fact that cardiovascular causes of sudden death are very frequent, and strategies need to be reinforced to control and help the people to be aware on how to control cardiovascular risk factors. And we're actually saying, as one of these new outreach missions effectively ongoing in the cardiac center, to continue to reinforce the education and awareness on these cardiovascular risk factors that may go a long way to help and curb cardiac deaths. With this, we thank you very much.
Thank you, Sister Ashoma, Sister Dr. Ashoma, for your brilliant presentation. We are going to take the questions